Hello everyone, thank you so much for joining the LAN today. We're going to get started a bit early so we have enough time for our speaker to present today. I'm your facilitator today. I'd like to take a quick moment to again thank you all for joining. If you have any questions, you can feel free to private message me in the chat box, or you can message everyone. I'd like to introduce our presenters today, Mary Erickson and Sarah Leek, as well as Dr. Assid. Today's agenda will be going through the March LAN poll results, measure definitions, and then we'll hand over to Dr. Assid as we go through ESI and Triage. And then we'll come back and go through some reporting processes and some service unit report out preparations. Now I'm going to hand over the mic to Mary Erickson.
Okay, thank you, Francesca. So we are rolling right into this from last month. We had the first LAN session about AIM-3, the IHS AIM-3 that is regarding care transitions. So during that March LAN, we did do a poll, so I appreciate the participation in that LAN poll, because we use that information to kind of gauge and do a little quick pulse check on where people are at with whatever topic we're covering. So we really appreciate your active involvement in our polling, which there will be additional stuff at the end today as well. So last time we talked about or asked you which part of the topic was the most challenging to implement. And the top 3 answers were post-discharge follow-up contact, evaluating ESI accuracy, and the discharge plan for each patient, and left without being seen rate. Those 2 questions or most challenging topics were tied for 3rd place in that poll. So that is kind of one of the reasons, and that is some of the driving factor with reaching out to our subject matter experts and helping them determine what we need to discuss. So we will be using this information and hopefully address some of these concerns and challenges for you today. The next question was, in what area would you like additional support? And the top answer to that was improving access to care to decrease left without being seen rates. The second one was implementing effective discharge planning. And the third was improving documentation and reporting from the ED dashboard. So these are definitely areas that we can use this information from the poll to focus on improvement efforts in these areas that you mentioned as high priority during the last LAN. So again, we appreciate that. The other thing, we know that that this is a kind of a heavy lift and a high resource type of measures and aim for IHS. So we just queried the group about what resources they plan to use for meeting this aim. And the top 4 were emergency department nurses, case management, registration desk staff, and the quality department staff. So thank you again for that participation in those polls. That's important stuff. So we wanted to give you a quick measure definition. So there's been a lot of discussion between IHS headquarters, the PATH project, and CMS, all 3 of us, different entities getting together to try and sort out the best way to proceed with this aim. So there are a few changes from the last LAN. So if you participated in March, we're going to go over those changes now. And hopefully by the end of it, it's clear for everybody. So the first one is that emergency department patients that are to be included in the discharge planning measure denominators are those discharged to all locations, with the only exclusions being hospital admissions and transfers. And the reason that we made this change in the language was because the list of discharge locations was getting really long. It was things like home, nursing home, jail. There was just getting to be too many things to really list out. So we thought that this was a little bit clearer of the intent of the measure. So for the discharge planning group of measures, exclude hospital admissions and transfers. And I just want to take a second here to highlight, when we go through the form later, the denominators are not the same across the board for all these measures. So be sure when you're doing your data collection that you use our tools around the definitions to be sure you're collecting the most appropriate data for that measure. So the second one was, last time we had mentioned that we were looking at narrowing the patient population to certain ESI levels, and we have done away with that because it was felt that it made it a little bit too confusing, and we just wanted to make sure that all patients were just treated the same across the board as far as the data and the measurements were concerned. So that is now all emergency department patients at all ESI levels are to be included in the patient population for all measures. So we aren't breaking out anything by ESI level is really the down and dirty of what that means. All measure targets are reverted back to 100%. We had made or tried to change the ED discharge follow-up and then left without being seen follow-up targets to 90%. And IHS feels very strongly that they really want to aim and shoot for 100%. So we're going to help you get there and see what we can do for best practices and improvement to get those processes and achieve that goal. So the details of updated measures are on the following slides and also available in the final measure definition handout that's available on the PathLAN website. So all the materials for AIM-3 are going to be at this website link. So even if you Google PathLAN 2019, tried it this morning and it popped right up. So if you go in there, you'll have the materials section, you'll have the recordings of the LANs that we're doing around AIM-3 and the materials associated with data collection. So we're trying to put all that in one place for you. So these slides will all be available there, as well as sent out, you know, the link to them sent out afterwards. So we'll get all of that information sent out as soon as possible. But wanted to make sure we had time to discuss it with you today first. So these are the updated measure definitions in a little bit more detail that I just discussed with you. So that updated in this lighter blue color here in the middle, that updated measure definition as of March, end of March. Actually, we were still discussing things as of yesterday. So we're trying to put a line in the sand now as to this is the end of measure changes. So hopefully we can hold to that. So with this one, you can see that language change I mentioned, excluding only hospital transfers and admissions. So everybody else should have a post-discharge or a discharge plan in their ED record. Same thing with this one. So in the ED measure group, the discharge planning group, there are 3 different measures. And so we've changed that language there for all 3 of those measures. So this one is 100% of all discharged patients, excluding only hospital transfers or admissions, will have a documented attempt to post-discharge phone contact within 2 business days by July of 2019. And the last measure, 100% of all discharged patients, excluding only hospital transfers or admissions, with provider follow-up documented in ED encounter, will have a documented attempt to post-discharge phone contact within 2 business days by July of 2019. Now, in theory, this one might be a sub-denominator category because you should be looking for those charts where the provider required follow-up. So they required a follow-up with a specialist or primary or whoever, and we recognize that these denominators may be very similar or the same, or they may not. So we're going to have to just look at that and watch that. But I wanted to point that out, that that is the difference between this measure and the other ones. The other update was this 100% target of left without being seen patients from an IHS emergency department will have a documented attempt to follow up phone contact within 2 business days. That was the only change with the left without being seen measures. The ED throughput measure, so there's a measure with CMS. The CMS outpatient measures 18, and measures 18 has several different components, but there's one specific component of that CMS outpatient measure 18B that is publicly reported data. And IHS is developing electronic clinical quality measures out of RPMS to be able to pull that data and submit it to CMS. So what we want to do here with this AIM is align those measures so that you are accustomed to collecting, reporting, and looking at that data even before you're pulling it out of RPMS. So we want to be sure that we're consistently aligned, and we do appreciate alignment of data and measures between federal agencies, between CMS and IHS. That is typically a good thing. So with that, I say that so that you understand that the difference between this measure's data collection is that it includes the discharge dispositions that are included in CMS Outpatient Measure 18B. So those discharge dispositions are 1, 2, 3, 4B, 4C, and 5. And number 1 is home. Number 2 is hospice home. Number 3 is hospice healthcare facility. Number 4B is acute care facility, critical access hospital. So this might include, I'm just going to point this out, that when you have a discharge disposition of an admission to a critical access hospital, that may be included in, that will include those patients in this measure. So if you have any questions about that, please let us know. The acute care facility, cancer hospital, children's hospital, or 5 other healthcare facility. So just pointing that out, that is different than what we had originally set out with this AIM. But again, after much discussion with IHS headquarters and CMS, trying to be consistent across all measurements. So we'll work through that and help you with what that means and help you collect that consistent data. So with the ED throughput measure, there are 3 different measures, and I've kind of broke them out here, that you're going to include these patients we just talked about with the discharge disposition, and you're going to measure the time of arrival to the time of triage. And many of you submitted that data in the baseline. The second measure, you're going to include those same patients with the discharge disposition, and you're going to measure the time of arrival to the time of the medical screening exam. And we recognize that this one is presenting more challenges, but we will get there. And the last one is the elapsed time in minutes between the time of arrival to the time of discharge. So those are the measure updates. There were no changes made to the ESI accuracy level measures, and there were no changes made to the left without being seen rate that is being collected. So with that, go ahead and put any questions about any of those measure updates in chat, and I'll try to answer them while we are listening to our wonderful guest speaker, Dr. Pamela Assid. We're very fortunate to have her here today. I heard her speak in Denver in October and was very impressed. Not only is she an engaging speaker, but she obviously knows what she's talking about and has been doing it for a long time. She's an emergency department director with Skyridge Medical Center in Colorado. She is responsible for ED operations, including throughput and staffing, growth of the ED service line, and finances related to ED, including adequate resources and equipment, as well as patient charges. She has over 20 years of leadership experience in the military as well as civilian healthcare systems. Thank you, Dr. Assid, for your service to our country. Pam's particular expertise is in utilizing best practices to enhance efficiencies as well as engage her team and ensure optimal outcomes. She accomplishes this by developing key leaders and encouraging the team to their own practice through shared governance committees. In addition to her extensive leadership experience, she's been active in her professional organization, the Emergency Nurses Association, by contributing to evidence-based training such as Trauma Nurse Core Curriculum, Emergency Nursing Pediatric Course, and has been an active Colorado ENA chapter, serving as the nurse practice chair before being selected as a member and then a chair. So we're very fortunate to have her speaking today, and I'm going to turn over the mic to Dr. Assid now.
Thank you, Mary. I appreciate it. Can everybody hear me okay?
Yes.
Wonderful. Okay. Based on what your survey results showed, we're going to go just a touch into ESI. You know, there's one thing that I've learned in all the years I've been doing this. If you focus on one thing, it actually impacts several other things. So if you're not really focused on your ESI assignment, that could potentially adversely impact your throughput, length of stay, and you've got lots of measures around that. My parent company is HCA, and we timestamp pretty much every single second of every patient's visit from the time they arrive to the time they leave the ER. There's so many ways you can cut the data, and I've had a lot of opportunity to look at ways to work smarter and not harder over the past several years. Next slide, please. So basically, what are we doing with triage? We're really just trying to sort. Triage is a verb, not a noun. That is sometimes a very difficult concept for emergency nurses to get. Oh no, this spot right here is the only spot I can triage a patient. You can triage a patient as soon as they walk in. And really, the point of this is that as we get more into the ER space and we start looking at better ways to provide care to patients, we have to be a lot more flexible with what that means and how that looks. Next slide, please. So what are our objectives? Well, we want to get the really sick patients out from the waiting room and into the main department where we can get their care started immediately. And then for those that are waiting, what can we do to get started for them so that we can continue their care instead of them sitting there for hours, nothing's going on, and their visits become 5, 6, 8 hours long when we probably could have had them in and out in about 2.5 hours. Next slide, please. What are some of our objectives? Again, we want to sort the sick patients from the not sick patients, but we also want to make sure that we are reassuring patients and families that they're getting the care they need and allaying some of their anxiety. We've all had situations where people come in and their hangnail is more important than the patient that's gray and gasping for air, because that's what's important to them. So how do we manage that while we're still taking care of sick patients and assure our community that we're here to take care of them and give them the necessary skills and resources they need so that they can get back to what their life is. Next slide, please. So ENA, the Emergency Nurses Association, which is the body that really governs the standards of care for the provision of emergency nursing in the country, as well as the American College of Emergency Physicians, our collaborative partner, and they're the oversight authority for emergency medicine physicians. They both endorse a 5-level triage system. There are many kinds. The one that is most widely utilized is the ESI Emergency Severity Index, and it's from the Agency for Healthcare Research and Quality, and the link is here on the slide for you. It is total open source, free. I believe it's up to 100 and some odd, 50 some odd pages now, with a little bit of an addendum that was done a few years ago. Specific for some special populations. It's one of the easier ones to use. The nice thing about ESI, it doesn't necessarily tie a time frame to your ESI level. The Canadian acuity triage system does. So sometimes as you're talking to people about 5-level acuity systems, oh, well, if you make them a level 1, they have to be seen within 5 minutes of arrival. Well, if they're level 1, I'm hoping they're seen within 5 minutes of arrival, because that means we're doing some kind of a life-saving intervention. But ESI does not actually have times tied to it. That's the Canadian acuity triage system. You can use anything that you want. There's some 9-level systems out there. Honestly, I think the more that you add to it, the more complex and complicated it becomes, and the harder it is then to assure that you're putting patients in the right category. 5 seems to be a really good magic number. Next slide, please. Again, we're using this so we can sort out sick versus not sick. Next slide, please. This is the ESI in a nutshell. This is something that you can get from AHRQ website specific for ESI, and this is what we build all of our training off of for our teams in our division emergency departments. It's a very easy flow chart. Are they using 0 resources, 1 source, lots of resource? Are they in a high-risk situation, or are they requiring immediate life-saving intervention? And then when you look at some of the text that goes with that, it tells you what's an immediate life-saving intervention, what's a high-risk situation, what are resources. This one's actually really important. For example, contacting a primary care provider for consultant, usually it's your QMP, your qualified medical provider that does that. That does not count as a resource, but contacting a specialist is a resource. Giving a tetanus shot and doing wound care is not resources, but doing IV fluids or doing a procedure such as a closed reduction are resources. So being able to parse out some of those are very important when you're looking at the ESI assignment and who can do what based on not just what ENA and ACEP say, but as well as your state guidelines and federal guidelines as well. And then there are some specific information that's included in this relative to the pediatric population when you're talking about a high-risk situation. So if a 14-day-old comes in with a temperature of 101, that patient should be an ESI 2, regardless of how they appear, because their temperature is greater than 100.4. So some of the little specialty things that you need to know. We actually were able to take this diagram, shrink it down, and put it on our badges as a reference so that our nurses, as we were going through training until they became a lot more familiar with it, had that reference readily available for them. Next slide, please. This is going to just give you some more specifics about what's an emergent versus a high-risk situation. I don't want to spend a lot of time on this. I want to make sure that we have plenty of time for discussion. And again, this is information you can get from AHRQ's website. Next slide, please. So here you're talking about where the bulk of our patients tend to fall. The CDC does a survey every few years trying to determine what kind of patients are coming to ERs in the country. And it's a huge document, the NCAM survey is what it's called. But the bulk of our patients that come to emergency departments tend to fall into the ESI 5, ESI 4, ESI 3 category. So your 5 patient, as one of my charge nurses likes to say, he could stay in his garage overnight for a week and still be the same chief complaint that he had when he went into the garage. So those are your stable patients that really need no resources. An ESI 4 patient, the patient needs one resource. They might just need a throat culture, or they might just need a chest x-ray. They really don't need a whole lot of care. Your 4 and 5 patients, in general, through most of the country, are referred to as your low acuity patients. These are the patients that, in general, should have been able to go to an urgent care or primary care physician's office instead of utilizing the emergency department. Now, that being said, there's going to be times that it's 100% appropriate that these patients come to the ER. On average, about 30% of patients that come to ERs are ESI 4 and 5. It is postulated out there, nobody's able to really study this, but it is postulated that if we had all of the mechanisms in our healthcare system set up appropriately, where we had easier access for primary care, we had more primary care physicians, etc., that really in the emergency department, we should see somewhere around 10 to 15% ESI 4 and 5 patients, because there are always going to be things that happen after hours that would require patients to seek care, and we might be the only option. But most ERs in the country sit somewhere around 30% ESI 4 and 5. That is a population that is very important for us to identify as leadership in the emergency department, because this is where you can gain a lot of efficiencies so that then you can have more time, if you will, to focus on your patients that fall into the ESI 3 or 2 category. ESI 3 patients typically require a lot more resources. These are in general are your back pain, your belly pain, your chest pain, your respiratory patients. They usually get IVs, they usually get labs, they usually get some kind of diagnostic imaging study, and they usually get medications. So they require quite a bit more effort and engagement than your 4 and 5. Next slide, please. Some of the legal issues. One of the things that I do on the side is I work with a couple law firms and do some consulting when they have a med mal case that comes up. Triage is one of the most litigated areas. I will tell you that in general, a lot of emergency departments tend to limit resources to triage. Thought process being, if I can get them back to a room and I can keep all my resources in the main department, then that will actually make things more efficient. I would argue that that is probably not accurate for the most of the ERs that I have assumed leadership roles in. The last 4 that I've worked in, we've actually flipped that thought process. And actually, I will say it was my team that started doing, they were the ones that wanted to try it at one of the very first ERs that I took a leadership role in. And I said, okay, but here's the rules, here's what the standards are, and this is what we have to follow. And they actually put more resources out in triage and decided what triage should and shouldn't do, and then ended up having less staff in the main department. So at times that meant that sometimes the primary nurse in the main department might have 5 patients instead of the typical 4-to-1 ratio. But by doing that, by pushing some things out front to be done ahead of time, what they found was they were getting their door to EKG times down to less than 10 minutes, that they were getting IVs started faster and labs sent sooner, so that we were getting results back faster, so that length of stay was decreasing, because they had more resources out front focusing on doing those tasks, getting patient history, and better able to determine where patients should go, whether they could be low acuity or if they needed actual RN in the back, and that they became more efficient in the main department by doing that. Not saying that's the perfect solution for every place, but it has worked, and I've been able to replicate that at 3 other ERs since then. It also dropped our left without being seen rate significantly, and it did decrease our length of stay. The current ER that I'm at, when I started here, the length of stay for patients going home was about 265 minutes. We are down to 165 minutes on average. And it takes time. This isn't a light switch. You can't say, oh, we're going to do this today and it's going to happen tomorrow. It takes time, it takes training, it takes engagement of the team to make it happen. But by doing this, we've actually avoided some complaints that patients have filed that could have been EMTALA complaints, but thankfully when they were investigated, they found, no, we actually had resourced things appropriately and this complaint is bogus. That cannot be said. One of my sister facilities in another state within my company actually received an EMTALA violation, a $100,000 fine, 18 months ago about, where they had a process in place where they had a provider that immediately greeted every patient that walked in the door. And by greeting, I mean they literally said hi. It's not like they did a whole lot of intake. But regardless, the provider had put orders on that patient's chart to be done, and they did not have resources pushed forward to that triage area. And it was an hour and a half before the orders were carried out. And it was determined that that was an EMTALA violation. It's not just a process of greeting. If a qualified medical provider determines that further testing is needed in order to say if the patient has an emergent or non-emergent medical condition, that it is the onus then becomes on the emergency department on the facility to ensure that those orders are carried out timely. And CMS did not feel that an hour and a half delay was timely. So they were actually cited and fined $100,000 for not carrying out orders that had been placed within 10 minutes of a patient's arrival. So triage is a pretty sticky, complicated area to be. I'm seeing on the chat some of the questions that are coming up. Triage is considered a nursing assessment. So a nurse needs to do triage. That being said, based on your state board of nursing rules and pre-hospital rules, because most states have a pre-hospital board and as well as a board of nursing, you can use some extenders in those roles. So the way that my particular facility does it, we have a nurse that oversees triage, we have paramedics, and I've got EMTs. And they work together as a team. They determine who does what parts of the process. Our paramedics, we did get permission through our pre-hospital board to allow paramedics to be trained in the use of ESI, because ESI is, in and of itself is not an assessment. What you're determining is what resources a patient will need. So as long as a nurse or a QMP has assessed the patient and said, we're going to need XYZ resources, then the paramedic can assign the ESI and determine appropriate placement in the department. Another question I think that somebody had popped up was about general flow and staffing. I will tell you that we do at times shortchange the main department to ensure we've got adequate resources up front. I love my company, but my company is focused on making sure that we provide high quality care as efficiently as possible and earning revenue. So it's not like I get lots of extra resources to sit around and do things. So I took a lot of time working both with my medical director as well as some of my finance people, and I pulled a lot of data when I started to determine how many patients are coming in, what's our average length of stay, how many butts do I have in beds, that determines how much staff I need to provide care, so that we could be strategic in determining what hours of the day can I reasonably have my nurses increase to a 5-to-1 ratio to ensure that I've got appropriate resources on my front end. Because at the peak part of the day, I need almost as many resources, if not more, in the back, because probably like several of your departments, sometimes we have an issue with getting patients out on the back end for admission. And so we have some hospital throughput issues. And so I have to look at and balance all that. So that's part of what my job is as the director of the department, is to look at where I can shift resources and change process as well as staffing to meet the needs of the patients that are coming in without compromising the process that my team created with getting that triage done as rapidly as possible. Next slide, please. Some of the considerations, and I alluded to these a little bit ago, when you've got a bunch of patients that are coming in, how do you manage that? Well, that's something that you need to think about. You need to look at what your flow is in your department. I can tell you in my department, since I started, how many patients showed up every single hour of the day, every single day of the week. What are my busiest days? What's my number of patients that are being admitted? How many EMS am I getting? When am I getting those patients? When are the bulk of my admissions? These are things that as a director or having some type of a operational oversight over an emergency department, you should be able to know, because that's how you're going to determine what resources you need where. When we've got wait times that are longer than 10 minutes for that quick across the room, hey, are you okay? Are you not okay? My charge nurses, they're in a different type of leadership role, so we call them clinical nurse coordinators or CNCs, but essentially they're responsible for the hour-to-hour operations of the department. They have to look at some where their resources are in the main department, and there's going to be times that they have to maybe take a patient assignment because something's happening. In general, I don't like my CNCs taking assignments so that they're available to the staff as a resource, but there are times that they have to. There are times that they have to call my manager or myself in. I worked yesterday, I ended up working most of a night shift before my day shift because that was what the need was of my department. But my boss is cool and he lets me have other time off, so it's fine. It all works out good. But we have to be able to utilize our resources effectively. And there are times that literally we think we're never going to get through because we have that many people piled up in the waiting room and that many people in the department. We always make it through. And those are the times where I really count on my leaders in my department to have a positive perspective. And we're going to take it one patient at a time. We're going to do the best we can do. And honestly, those are some of the days that we do the best performances that we've ever had. Because everyone's feeling the pressure, including my providers, to move patients through. One of the things that we put in to place about 15 months ago was reassessing patients waiting in the waiting room. We were really good about doing that with our ESI 2 patients. My emergency department here is very different than every other ER I've ever worked in. We have less than 10% low acuity patients. I typically only have about 8%, because most of my patients, I happen to be in a community where most of my patients have insurance and they have primary care doctors, and they prefer to go see them than come to the ER. So usually by the time we see them in the ER, they are very sick and they require a lot of resources. So I am crazy skewed to the ESI 1, 2, and 3 categories. So we will have long waits sometimes for our ESI 3s. And so we have put a process into place with reassessing our ESI 2s and 3s, and I audit that every month to make sure that we are doing some kind of a reassessment every hour while they're sitting in the waiting room. And it's a challenge sometimes, but again, we've learned through trial and error where we have some of our pain points, where do we need to have something that can support us within even our own facility, reaching out to some of the other departments. Sometimes ICU has a nurse that only has one patient, and so their charge nurse will send them over to help us for an hour. That can make a huge difference. Most problems in the ER are 2-hour problems. So if we can get someone to come over and even just transport 2 patients out of our department and open up 2 spots, that can help. So sometimes going outside the department is big for us. Next slide, please. So some of our strategies that we have in place to ensure that we're properly assigning our ESI. First of all, research indicates nurses under triage consistently. We're doing a very quick snapshot in time when the patient comes in, trying to figure out what category they go in, but then the provider goes in, does a much more thorough H&P, and determines there's a lot more resources that are needed, or the patient ends up being sicker than we thought. Rarely are we going back and changing those ESI. We need to be doing that. So every day I go through probably, we see about 100 patients on average. I go through about 55 to 60 charts a day, and to look at their accuracy. So I review 100% of our ESI 3, 4, and 5 charts. And as I do that, determine based on the orders, based on the patient's vital signs and their presentation, should we have changed this patient's ESI level based on the AHRQ ESI manual. If I determine that we, in fact, should have elevated that ESI level, I send a notice to that nurse, and I have a tracker. And at the end of each month, my nurses all get, we call it a dashboard, it's a scorecard, and ESI accuracy is part of that. My goal for my nurses is 90% accuracy. The literature doesn't actually establish a goal, but most of it's somewhere between 90 to 95%. We've hit at 90% very consistently for about the last 6 months. So I've been doing this for 14 months now, and the feedback I send my nurses is fairly minimal anymore. Because they're in tune now. They get it. They are knowing, and so there's a lot less back-end processing that's having to go on. So my chart audits, when I started, it's taken me probably 3 hours a day. Now I can get them done usually in less than 45 minutes because the nurses are doing a much better job on the front end. They really don't like getting emails saying that they had an opportunity to do better, because probably like most of your staff, my nurses are very competitive and high functioning, and they like to think they do everything perfectly well. So when they find out they're not, they take it as a challenge to do better. And that's not me saying they have to do better, that's them doing it. So they do get that feedback every month as an aggregate of how they're doing. Next slide, please. So general throughput. My understanding of IHS is that there is an expectation for an overall discharge length of stay of 120 minutes. And for the most part, this is pretty much industry standard. 120 to 125 minutes is industry standard for discharge length of stay. In order to do that, what I've done here in my department, because my company currently, our discharge length of stay goal is 125 minutes. We literally look at every single step of the process, from the time they walk in to the time that they are treated, from the time they walk in to the time a provider sees them. 2 measures that Mary just discussed with you guys. same things I'm held accountable for. From the time that they're greeted by a provider till they have the first order, from the time they have the first order till it's actually carried out, from the time an antibiotic's ordered till the time it's given, pain meds, from everything, every single step of the whole process is timestamped. We use electronic documentation. It's probably not, I'd say it's a basic system that we use. It's not bottom of the barrel. It's certainly not top of cream of the crop. It's decent. However, what we've done is we've put time with each of those steps in order to ensure that we can hit that 125-minute target. I will also tell you, my department does not hit that 125-minute target. The reason being that I've got such a skew with my ESI on the 1, 2, and 3. So I've worked through with my from my local team through my corporate team on what a reasonable target for us is. It was determined a reasonable target for us is 165 minutes. I can tell you I don't hit that, I come close. Most months, our discharge length of stay is somewhere around 167 to 169 minutes. We still have opportunity. There's a couple of strategies we're currently working on with some technology to help with this that we think will actually shave a minute or two off, and we're that close. But just realize that it sounds daunting. It can be daunting, but even with all of the things I'm telling you, my team is still not hitting it, although we continue to make improvement. And from my corporate perspective, that's really where they want us to be. We have decreased our left without medical screening exam rate. We have a very low AMA rate, and they consider that to be excellent as well because we have some of the processes in place we do. So that does buy me a little bit of good juju with them. Next slide, please. I understand that left without being seen rate can be challenging in some of your facilities. They have been in some of the ones I've worked in as well. And one of the things that we have done is we've really pushed our providers to mirror the process we have on the nursing side, where we're implementing an immediate rapid triage, that they are immediately greeting patients, which doesn't just mean looking at them and saying hi. It means actually getting information to determine the best course of action. I am very blessed. I have an incredible medical director that's engaged, and he holds his providers accountable to that. Research has shown that the sooner you greet a patient, you being a provider, and the sooner that the patient feels care is being started, that's on us as the nursing team, that you're left without being seen percentages will drop. My current ER, we've got a significant hospital throughput issue, so my admissions tend to sit in my ER for hours on end. I frequently am seeing patients and discharging them out of the waiting room. There's a way that we've scripted that to the point that we have patients that as they come in, they go, you know, I don't really think I'm sick enough for a bed, but I'm really not feeling good. We start IV fluids out in the waiting room. We start non-sedating medications and medications that don't require monitoring. And there are many times we're discharging patients out of our waiting room and home because we never even got them into the main department because I didn't even have a bed for them. But our community understands, we script, we explain. 98% of the time that works. You'll always have those outliers that don't like it. The bigger problem with your patients leave without being seen, though, is that realize whatever your admission percentage rate is. So we admit about 30% of the patients in my ER. That means about 30% of my patients who left without being seen probably were sick enough to be admitted, but they left. So we were unable to get them the care that they needed. Hopefully they went somewhere else and got it. We don't know. Most of our left without being seen patients do not call us back. We reach out to them, they don't call us back. We do have a very low left without being seen rate. It's about 0.4%, 0.35, 0.4% of our patients leave without being seen. It does make it a little easier for us to do follow-up. They just usually don't call us back. But it is kind of scary from the patient care and quality perspective to realize that 1 of 3 left without being seen patients from my department probably should have been admitted. So some of the basic principles, we talked about this. I'm not going to harp on this because I want to make sure that we get to a slide that I have closer to the end. The next slide, please. These are all example front-end processes. We can kind of fly through these. These are just some quick decision-making flowcharts, different things that either I've been part of at different organizations or that I found in the literature to throw out there for you all to look at, to consider, not that you have to implement in any of these. Starting with this intake flowchart, the next several slides all tie back to this concept. This was a big concept that was created by a team that I've worked with, and they put this together. It was quite good. We can flip through the majority of these slides. Next slide. They did a really good job of assigning who to what roles. They assigned a bunch of different types of alerts that then notifies the charge nurse or CNC this patient needs to come back sooner than other patients. Next slide, please. What the charge nurse role is in this particular process. Next slide, please. And then what all the different stations are they have set up. Next slide. Somebody just threw up a question about left without being seen rate, 0.4%. It is, my AMA rate is about the same. So combined, my left without being seen and my AMA rate is less than 1%. What other questions?
Okay, so yeah, there was a couple other questions. One from Dave Civic was talking about the ESI accuracy. Is there a tool that you use to do that, to measure that accuracy?
So back in the presentation, the slide that had the ESI flowchart with some of the explanations to the side, that's exactly how I do it. I look at the chart, I look at the patient's initial presentation, I look at their initial vital signs based on their age, I look at what the orders were that were put in, and then I try to reconstruct from that moment, did we do the right thing for this patient? Did we put him in the right ESI category? My group of hospitals, we call ourselves a division in the Denver area, my division, we've actually come together to standardize how we all are approaching our triaging of our patients. So there are some patients that, we get a lot of chest pain patients, probably like most of you guys, it's probably one of your top 10 chief complaints. But as the providers are talking to the patients, as they're determining, hey, this one is stable to go, this one is going to need a 3-hour EKG and repeat troponin, that's going to change the patient's acuity level. They're no longer necessarily going to be an ESI 3, they might be an ESI 2. So we decided as a group some of those special situations. Things like stroke alerts, that within our own hospital, the 6 hospitals in our Denver market, we had quite the discussion last week. Our stroke alerts an ESI 1 or a 2. Well, we're not necessarily doing a life-saving intervention. I don't know about you guys. I don't intubate all my stroke alerts. In fact, a good chunk of my stroke alerts go home. So no, I don't think they're ESI 1s just because they're stroke alerts. And if you look at the AHRQ manual, it does say in there that just because you're some type of an activation doesn't mean that you're an ESI 1. So everything goes back to looking at that manual. And those are where the decisions are coming from.
Okay, so we had another question that our 3, 4s, and 5s are 70% of an average around 120 patients a day. What do you recommend for percentage of chart reviews?
I look at 100% of my ESI 3, 4s, and 5s. Those tend to be where we've got the most opportunity. I've got 35 nurses, and so for me to say, oh, I'm only going to look at 5 charts for each nurse each month, personally, I find that's unfair to the nurse to say, well, you missed 1 of 5 charts with your ESI level for the month, so you're an 80%, versus, hey, I looked at all 94 of your charts for the month and you only missed 2. And like I said, as I don't know, again, I don't know your teams, but most of the ER teams I've worked with, that is kind of like a personal upfront that I didn't do something right, and they take it as a challenge. In the beginning, it took me a long time to look at that many charts. Now it's down to usually less than 40 minutes a day, because it's not as many charts where there's discrepancies that I have to go back to the nurse and re-educate them. So their percentages of accuracy have been a lot higher, particularly in the last 6 months. Like I said, we see about 100 patients a day. I'm heavily skewed on my high acuity. 75% of my patients are ESI 3s. So I am reviewing about 80 charts a day to count my 3, 4s, and 5s. A lot of those I'm doing real time, because I'm usually out in the department, I'm floating around, and I'm like, hey, I just happened to look at this chart with this patient. This is what I'm seeing. Are you really sure they're an ESI 4? And my nurse, oh man, I forgot to change it, and I'll change it right there. So there's some of that real time conversation that goes on as well. But it's a process. You know, if you're an ER that sees 300 patients a day, there's no way that I would, me personally, be able to do that. I'd have to probably have somebody. But if I'm seeing 300 patients a day, hopefully I'd have somebody full time to oversee some of the quality documentation of charting and able to do that. If not, I can tell you some of my sister facilities, they're not as engaged, the directors, at reviewing as many charts as I do. So they only look at 10 charts per nurse per month, and they feel that that gives them an adequate sampling. So there is no standard in the literature. I would say probably it would be a good idea for you guys as a group to decide what's reasonable to do given what resources you have, and working through your chain of command to ensure that that sounds reasonable to them as well, to ensure you're getting that accurate level. Because once you can make sure you're getting your patients in the right category, then you can assign times to them. So for example, my ESI 4s and 5s, it's only 8% of my population, but we want those patients out the door. From the time they walk in to the time they leave, we want them discharged in 85 minutes. That means I have to have my providers engaged. I have to have my team up front engaged to say, whoa, this is a low acuity patient. We need to get things moving faster on this patient than we do maybe on this other patient, because we've got other resources that can take care of this other patient, the ESI 3 patient. So we've got actually different times assigned by ESI category. So knowing how many patients I have in each category is very important for me. So I can say, okay, for my ESI 3s, that's 165 from time you walk in to the time you leave. My ESI 2s, I have to have them out in and out the door in 200 minutes. My ESI 1s, I have to have them in and out the door in 100 minutes. The patients that are my ESI 1s, though, are either going to the OR or ICU. Well, I've had to work with those departments to streamline some processes so I can get patients out faster on the back end to hit that 100-minute target. That's what gives me the ability to have my ESI 3s at 165-minute length of stay. But you have to make sure you have your patients in the right categories in order to find the appropriate time frame. So if they're not properly being categorized, it becomes that much more challenging to ensure that you're hitting the right time frame. And that's going to make it harder to hit that overall discharge length of stay of 120 minutes.
Okay, Doctor.
Does that make sense?
Yep. There's just a couple more questions I want to really quickly get to. One about where are you discharging to? And then how many charts?
Same places that were on your slide for OP18.
Yeah, right? Okay.
Yeah, we discharge 70% of our patients out of the hospital.
Okay.
30% are admitted.
Okay. And I know that there's more questions, so we have about 10 minutes left here and a couple more things to go over on the ongoing reporting process. We are, I told you guys she was good, right? So she's coming back in June. And if you have additional questions that we're not able to get to, we're gonna go ahead and put those in chat, and we will summarize that information and submit it to Dr. Assid for some responses, if that's okay.
Absolutely, yeah.
Thank you so much. That was great information for our group today. And go ahead, like I said, put your information in chat or your questions, and we'll get some more answers to you. And we are definitely having her back. So I just want to talk for a minute on the process for AIM-3 data collection and submission to PATH. So the process is as follows. You will collect your data internally on a monthly basis using the numerator denominator information that's presented. So we did not prescribe an internal data collection process for these measures simply because, or a tool, essentially. We do have tools available if you need them, but we recognize that you might have different people involved, you might have existing processes, and we wanted to encourage you to use those existing data collection processes as opposed to prescribing one for you. So then you're going to utilize a fillable PDF that I'll show you here in just a minute to input the requested data. That will be available at the PATH LAN website today, and submit that PDF. And if you're submitting ED dashboard data to Artis Cochran at healthinsight.org using the IHS secure file transfer service that is accessible to everyone. So if you need help with that, let us know. The first data submission deadline will be April 19th for January, February, and March. You do need to submit data for each month individually. CMS would like us to work on this data monthly with you. So following that, it is going to be, need to be submitted each month. So if you have challenges with that, please let us know. So I am gonna share the form really quickly here. Nope, that's not the form. That is the data definition page. There we go. Here's the form. So we've tried to make it as straightforward as possible. You're going to enter your information, the reporting month, who you're going to submit your data to here, and you're going to submit questions to Artis as well. She works with Health Insight and has been just a huge help in this tool. So the emergency department planning, this is where you need to pay attention to the questions about the denominators that I said. They might be a little bit different depending on the measure group. If you're going to use a sample size as opposed to doing like a 100% review, then you would need to indicate that and indicate the size of the sample. So please be sure you're giving us numerators and denominators and not rates. When we're aggregating data at a higher level, we need to have the numerator denominator for a more accurate overall and aggregate rate by area and by nation. We are looking for, in the discharge planning measure, evidence in the chart that they were sent home with a discharge plan, evidence in the chart that there was provider follow-up required for that particular measure, and then also documented attempt of phone contact. So we did not say that that necessarily needs to be in the chart, although some service units are deciding to put it there. So we're not prescribing that either. Triage and ESI accuracy, part of the measures is that needs to be included in your QAPI process on a monthly basis, so we're asking you that. Again, emergency department visits, or if you're doing a sample size for the ESI chart review, and that is based on the ESI AHRQ tool and validating that information there. Last two measure groups are left without being seen in the ED dashboards or the ED throughput. These are two measure groups that can be submitted using the ED dashboard if you're using that. So if you are using that and can submit that ED dashboard raw data, or you can use ED dashboard aggregated internally, but you do need to give us the numerator denominator and not the rate that's calculated. Or if you're collecting that data manually, then you may also enter that numerator and denominator as well. On ED throughput, we put the discharge codes that I mentioned earlier right here on the form, so that hopefully that helps with consistency in the data that we're going to receive from you. Again, you can submit the raw data from the ED dashboard. You can aggregate it internally, and I will again emphasize this is median times, not averages. So please be sure you're looking at median times and not the averages. The data collected manually, same thing. This is from the ED dashboard, and this is from if you're doing it manually. So you're going to submit this form using the IHS Secure File Transfer Service. We are also putting instructions, detailed instructions on the website with these materials, so you'll have those as well, and it will go over any other questions. So I know we're getting really down to the wire on time, so let me scoot a little too fast there. So these are the measures that are going to be submitted, can be submitted either using the ED dashboard, and the measures on the right are the ones that are going to most likely require manual collection. A flow of the process, so the service units are going to submit data to Health Insight via the IHS Secure Transfer Service. Health Insight's going to aggregate and analyze that data, and then we're going to give you some feedback, hopefully planning to give feedback to service units and area offices, IHS and CMS within 2 weeks of the data deadline. So that is, and if you want your data in there to be benchmark with everyone else, we do need to get everybody going on the deadlines. So the last thing that I wanted to mention today, we want to hear from you in May. We want to hear how things are going. Or how they're not going. You know, it's a status report. It's not necessarily we've met everything report. So there is a PowerPoint that you need to submit to your PATH project manager by April 19th as well, so that we can have active discussion between service units with IHS, CMS, and ourselves on May 1st, I believe it is. So I put a summary of the important deadlines. They actually are all April 19th. So just remember, April 19th is an important day to have all this stuff. We are here to help you, and we will do our best to support you in getting all of these things done and met. So each month, Carrie brings up a good point in the chat. I just want to emphasize each month needs its own sheet or document. For this first data submission that you're going to submit by April 19th, you will have 3 forms. Normally, you will only have 1 form to submit every month. So our next LAN is all about you, so we hope to hear from you by April 19th. Okay, well, that's all for today. Thank you, everyone, for joining us. We will be in touch. Have a great day.